Management. Perimenopause is a natural stage of life. It is not a disease or a disorder, and therefore it does not automatically require any kind of medical treatment at all. However, in those cases where the physical, mental, and emotional effects of perimenopause are strong enough that they significantly disrupt the everyday life of the woman experiencing them, palliative medical therapy may sometimes be appropriate. Hormone replacement therapy. In the context of menopause, hormone replacement therapy or HRT, known in Britain as hormone therapy or HIT, refers to the use of estrogen plus progestin for a woman who has an intact uterus, or estrogen alone for a woman who has had a hysterectomy. 34. Traditionally such therapy was provided as tablets but now is available in a range of formulations including skin patches, gels, skin sprays, subcutaneous implants and so forth. A popular alternative to conventional HRT is a synthetic hormone derived from the Mexican yam called tibolone. Of the non-hormonal therapies for hot flushes, some of the SRS appear to provide some pharmaceutical relief. 35. Adverse effects of HRT appear to vary according to formulation and dose. See the section below on adverse effects of conjugated equine estrogens. In addition to relief from hot flashes, hormone therapy can alleviate vaginal dryness, improve sleep quality and joint pain. It is also extremely effective for preventing bone loss and osteoporotic fracture. 36. A woman and her doctor should carefully review her situation, her complaints and her relative risk before determining whether the benefits of HIT/HRT or other therapies outweigh the risks. Until more becomes understood about the possible risks, women who elect to use hormone replacement therapy are generally well advised to take the lowest effective dose of hormones for the shortest period possible, and to question their doctors as to whether certain forms might pose fewer dangers of clots or cancer than others. Until recently, the most widely used estrogen preparation worldwide in postmenopausal women was oral conjugated equine estrogens. Other oral estrogen preparations include synthetically derived piperazine estrone sulfate, estriol, micronized estradiol and estradiol valerate. Estradiol may also be used transdermally as a patch or gel, as a slow-release percutaneous implant, and more recently as a metered-dose skin spray. Intravaginal estrogens include topical estradiol in the form of a ring or pessary, estriol in pessary or cream form, denoestrol and conjugated estrogens in the form of creams. Oral micronized estradiol and other oral estrogen preparations may result in up to 10-fold higher levels of circulating estrone sulfate than transdermally administered estradiol at comparable or even higher doses. 37. This is of concern in that estrogen-sensitive tissues such as breast and endometrium have high capacity to metabolize estrone sulfate through to estradiol. Orally administered estrogen therapy also increases sex hormone binding globulin SHBG to a greater extent than non-orally administered estrogens. SHBG binds estrogen and testosterone in the blood, and this may result in a clinically significant reduction in the bioavailability of these hormones. Thus it would seem that the prescription of oral estrogen therapy should be at the lowest available dose to minimize effects on circulating estrone sulfate and SHBG. In those women who have no uterus, usually due to a previous hysterectomy, estrogen alone is a suitable hormone therapy and is in fact preferable to continuing to use progesterone when its function as a moderating influence on growth of the endometrium uterine lining is no longer required. Women who still have a uterus need to take progesterone in addition to estrogen in order to protect against the development of endometrial hyperplasia and endometrial carcinoma. Oral administration of progesterone is convenient, however the oral micronized form is rapidly metabolized and inactivated in the liver, therefore high doses must be administered to achieve adequate circulating blood levels. Synthetic progestins have been developed and are prescribed to overcome this problem. Synthetic progestins are more resistant to liver metabolism, therefore lower doses can be used to achieve the desired endometrial effect. It is not uncommon for women to experience side effects with progesterone or progestin therapy. Progesterone may cause sedation, so is best taken at bedtime. 38. Synthetic progestins may cause irritability and mood changes in some women. 39.